So thank you, Kashish. Thank you, organizers. And thank you, Dr. Vamshi, for having me here. It's a very fascinating topic this day, that year. What I understood of this topic is, and what I think I'm going to do in this 10 minutes talk is take you through the evolution of treatments, how we have evolved for metastatic gastroesophageal cancers over last 5 to 6 years of ASCO. So in 2015, when I was still a fellow, it used to be a very simple treatment paradigm. If you had a stage 4 gastroesophageal cancers, we had only one biomarker. You do HER2, if it is positive, you go TOGA route, that is trastuzumab plus chemo. And if you are negative, you go just chemotherapy alone, either doublet or triplet with BCL. And when you progressed, you had paclitaxel ramucirumab. So this is all we had for stage 4 gastroesophageal carcinomas. So in 2015, this was presented at ASCO when Cyramza data was published. Later on in subsequent ASCOs in 2016, this was a very riveting paper. It was a phase 1 trial of pembrolizumab in gastric cancer, adenocarcinomas. During that time, kidney cancer, lung cancer, and melanomas had successes with immune checkpoint inhibitors, and it was always a matter of time when we would try for gastric cancer. And what was seen in this phase 1 was there was definitely a cohort of patients which did benefit from treatment with pembrolizumab. Of course, the next step was to take it through the phase 2s and phase 3s. And later in 2017 ASCO, this was presented, Keynote 59, phase 2 of pembrolizumab for subsequent lines gastric cancer. This time they wanted to test a biomarker, whether PD-L1 is a good biomarker for stomach cancer. And what was seen is the green bars, as you can see, the PD-L1 was not a good biomarker for this. Having said that, there was definite group of patients which did benefit from pembrolizumab. It's just that we didn't know what was that. Later on, the same group took this drug to the phase 3 manner, comparing head-to-head with paclitaxel next year in 2018. Although one could argue why not paclitaxel ramucirumab, because that was standard. But again, a classic curve, the crossing of curves, which we see for immune checkpoint inhibitors in all cancers. But based on that, it was shown that pembrolizumab does have some patients where it will give a better benefit than chemotherapy. During the same time, nivolumab was not lagging behind. It came up with attraction 2 in ASCO 2017, and it compared nivolumab against placebo in third line and beyond, and showed that there was improvement in overall survival. During this time, there were several group of investigators who were trying to evaluate the biomarker. There was a desperate need of biomarker, and a seminal paper in 2015 showed that if you are MSI high, the responses with immune checkpoint inhibitors were dramatic. And as you can see, these black bars were gastric cancers, and they also derived great benefit from pembrolizumab. So Kim and colleagues, what they did is took this phase 2 trial of Keynote 59 and 61, and they did a retrospective analysis and found that if you had MSI high, shown by the red bars, the benefit of Keytruda or pembrolizumab was more pronounced rather than if you were negative. So based on that, in 2017, this is what the cartoon looked like. In ASCO 2017, we had immune checkpoint inhibitor approval in third line, irrespective of PD-L1. And perhaps in second line, if you had MSI high, we would give either pembro or nivo. Later on, obviously, pembrolizumab was propelled into first line. Keynote 62, we all remember this from ASCO 2019, 2 years ago. This was a very, very confusing trial. It caused more questions than answers, that whether CPS score more than 1 or CPS score more than 10, the benefit of pembrolizumab compared to chemotherapy in first line was not there. And strangely so, pembro plus chemo should have been a better combo compared to chemo alone, like we learned from lung cancer, but it was not so. In fact, pembro alone was slightly better than chemo alone in CPS more than 10. So this was very confusing. But again, the same group did a retrospective research, what happened to MSI high patients. So again, 5% of patients from Keynote 62 were MSI high, mind you, first line. and giving them Pembro first line almost doubled their overall survival. So based on that, in 2019, there was some suggestion that if we may have found a new biomarker for the first line apart from HER2, and if you are MSI high, perhaps immune checkpoint inhibitor is the way to go in first line gastroesophageal adenocarcinoma. Then we all remember last year ASCO, there was plethora of trials, 2 with nivolumab and 1 with pembrolizumab, testing first line immune checkpoint inhibitor compared to chemotherapy alone. These were global trials. And irrespective of the study design, there was almost 15 to 20% improvement in overall response rate with promising progression-free survival hazard ratios 0.68. Now, again, confusion started for overall survival when they did a biomarker analysis. If you had CPS more than 5, the hazard ratio is 0.71. And the authors were very smart. What they did is they said CPS more than 1, the hazard ratio is 0.77, which is still positive. But what they did not mention is what happened between 1 to 5, because more than 1 also include more than 5. So after coaxing the authors, they had to publish this data that CPS more than 1 to 5, the hazard ratio is only 0.96, which is not better than chemotherapy alone. Nevertheless, in 2020, last year, this is what was developed. The sky blue bars came into approval that if you had CPS more than 5, first line stage 4 metastatic gastroesophageal adenocarcinoma, the way to treat them is IO plus chemotherapy. FDA has given the approval. FDA has also approved for any CPS more than 1, but my take is if you have CPS less than 5, I think so we are better suited with just doublet or triplet chemotherapy and reserving immune checkpoint for later lines. Now, what happened this year? One more thing before that, the HER2 segment. So this was all a non-HER2 segment. What happened in HER2 segment? Now, HER2 was a very disappointing segment. We had lapatinib with Titan, we had Jacob with pertuzumab, we had Gatsby with TDM1. All of them failed, like you would expect to benefit just like breast cancer, but none of them succeeded in gastric cancer. However, this AstraZeneca molecule and HER2 showed a dramatic responses, like you can see from this waterfall, in subsequent lines in gastric cancer. And based on that, FDA gave Enhertu a nod earlier this year. If you fail on trastuzumab-based therapy and still HER2 positive, you go on Enhertu. So this was there earlier this year. And very amazingly, this ASCO 21, Dr. Genjijian from Memorial and her colleagues did pembrolizumab plus toga versus toga alone in first line HER2 positive. Large 700 patient data. This was an interim result, which I'm sure somebody is going to discuss later in the day. But 22% absolute difference in response rates, more complete response and more partial response. Of course, we are waiting for the survival analysis. This is just interim analysis. But based on this, FDA gave approval just 2 months ago, accelerated approval for using checkpoint inhibitors along with toga like combo in HER2 positive first line. And this has become the new standard of care. So what we see today, right now, as we speak, this is how the cartoon looks like. You can see these purple bars, the purple arrows. The toga has been shifted to toga plus immune checkpoint inhibitor. And when they progress, instead of going for Paclitaxel, you can you have option of Enhertu, although it's not available in India. Now I know Anant is going to talk about what's in future. So I think in next 3 to 4 years, we are going to have several of these question marks filled in with either FGFRs or EGFRs or DNA mismatch repair. But what started from just a simple HER2 is now a very complicated cartoon of following gastric cancer in 21 and perhaps in 3 to 4 years from now.
So 1 minute left, sir.
Thank you for your patient listening. Thank you.